Let's start. Welcome back to the Inside seminar webinar. I mean, this is now a tradition. Thanks to an unrestricted grant of Novartis, we were able to have this kind of opportunity to meet periodically all together and to discuss on some cases. Today, we have the great privilege to have an outstanding moderator that is Ivona Ksantievic. Thank you, Ivona. And a fantastic opportunity to have with us Troy Torgerson that Ivona will present and Clinton Dunn will present very soon. Just as a president of ISAID, I'm so glad that Troy, that is the president of Clinical Immunology Society, accept to give this webinar. There is a very good link and a friendship between ISAID and Chase, and so that's why we asked Troy, and we are so happy that he was so kind to accept to give this talk. Thank you very much, Troy. Please, Ivona. Ivona collapsed because it happened also last time, because Ivona, I don't know, at a certain point at the topic moment, the PC I think collapsed. So I'm sorry, because
she's going to have me introduce Clint anyway, so maybe we could start there, and Clint can present the case, and then Ivona can join. So thank you, Marco, for that very generous introduction, and it's really a pleasure to be here, and thank you for the invitation to speak today. So we're going to talk about primary immune regulatory disorders today, and certainly many overlaps with diseases that ISAID is very interested in. And so we're going to start with a case presentation by Clint Dunn. Clint is a fellow here in Seattle. He's one of the senior fellows in allergy immunology at the University of Washington and Seattle Children's. And he's got a great case to start off with that illustrates many of the challenges that these patients pose, and then we'll take it from there. So Clint, go ahead.
Thank you for allowing me to join it with everybody and present an interesting case that we follow in our clinic. So this was a 10-year-old female. She initially came to our attention with about 2-day history of fatigue, feeling like her heart was racing, and dizziness and lightheaded when changing positions. Her primary care doctor had done a complete blood count. She was noticed to have a hematocrit of 13.5 and an absolute neutrophil count of 459. She was promptly transitioned over to the Seattle Children's Hospital, was admitted, did receive a packed red blood cell transfusion, and she had screening labs. She was found to have, she was DAT positive, she was ANA negative, she had an atypical C-ANCA with an elevated myeloperoxidase, but a normal PR3. She was transfused, her symptoms resolved. She initially was then discharged home, and she was established in our clinic shortly thereafter alongside our colleagues in hematology. A couple of weeks later, she started to develop isolated right knee swelling and had an x-ray obtained that showed joint fluid. And she was starting to have kind of joint pains and signs of inflammation. When we were assessing her and taking her history, she was the oldest child of a non-consanguineous union. She had 2 younger brothers and 1 younger sister. Her younger brother had immune thrombocytopenic purpura as well as type 1 diabetes. And then her other brother had an autoimmune hepatitis and developmental delay. Her sister, she had chronic anemia as well as asthma and abdominal pain that started when she was 13 years old. Her mother, unfortunately, was deceased. She had multiple cytopenias, and she unfortunately passed away from necrotizing fasciitis as well as myelodysplasia in her 30s. Her father, as far as we know, is unaffected and has no medical problems. And then her grandmother also had myelodysplasia and unfortunately passed away. During her course, initially she was treated with steroids with her autoimmune hemolytic anemia. And then as she was getting older, she started to develop recurrent sinus infections, chronic cough. When we repeated a lot of her immunologic studies, she was found to be hypogammaglobulinemic. with reduced titers. Due to her chronic cough, as well as the finding of hypogammaglobulinemia, she did have a chest CT, which showed patchy infiltrates, as you can see on the right side. She was ultimately diagnosed with GL-ILD, and she was also noted on her CT to have a pretty enlarged spleen that was present on physical exam as well. At that time, due to the GL-ILD, as well as the hypogammaglobulinemia, she was started on IVIG, and she was treated with rituximab and methylprednisolone pulse doses. This is kind of her story as she went on from her initial presentation on the left, kind of over 7 years, as we followed her closely. Her hematocrit did normalize once we started treating her with pulse dose steroids. Her platelet count never dropped significantly to the part where we were concerned about bleeding, or was significantly less than 50, but did kind of have waxing and waning lower levels at times in the 80s to 100,000, and her neutrophil count did periodically decrease, both outside of treatment when she was on steroids, as well as when she was on steroids. Ultimately, due to the finding of autoimmune phenotype, as well as the CVID-like presentation, she did have genetic testing and was found to be heterozygous in the CTLA4 gene, which is below. So her CTLA4 protein was truncated, and she was noted in retroactively. We screened brother and sister who were also affected, going along with their similar symptoms of presentation. So just to review, in the co-stimulation of T cells, whenever you have the antigen presenting cell come in and present on the MHC molecule to the TCR, B712 or CD8086 interacts with CD28 to upregulate her signal and allow it to progress on to produce cytokines and effector molecules. But the CTLA4, as I kind of like to think about, is the brakes. So it is produced after the CD28. It decreases how much CD8086 is on the antigen presenting cell, and kind of shuts off the co-stimulation from the antigen presenting cell to the T cell. And there is a produced a combined protein known as abatacept. It's a combined protein with CTLA4 with the IgG1 protein that is a regular infusion. We initiated that on her once we knew her genetics. And after we initiated that with her, she started to notice improvement in her baseline pulmonary functions. Her cytopenias largely improved, including her hematocrit. You kind of see that it trended upward, and then her platelet count stayed stable and her neutrophil count fluctuated upward. She is now 17 years old with a known molecular diagnosis of CTLA4 haploinsufficiency. She is being treated with CTLA4 combined protein with immunoglobulin. She is planning to go to college. She is desiring to work. She feels tied down by a lot of the frequent infections, and so she's raised a question to our clinic that she wants to be healthy. She wants to make progress in her life and not to feel hampered. It shows she desired to pursue potentially a hematopoietic stem cell transplantation. Unfortunately, 2 of her 3 siblings are affected as well, and the alternative one is not a match. Her mother is deceased, and her biologic dad is not involved in her care and is unwilling to donate. She does not have a matched unrelated donor available on multiple international searches. In her cord blood, she has 1 5 out of 6 mismatched cord with a lower cell dose, so she would ultimately require a second 4 out of 6 for a double cord transfusion. So we currently have continued her on her current therapies, but it does raise an interesting question about the longevity of treating with the CTLA4 hybrid protein, as well as the long-term transplant versus non-transplant opportunities. And I know that Dr. Torgerson can chime in on a lot of this. And these are questions that we have asked immersed ourselves multiple times in the care for her. And specifically, transplantation isn't easy for most patients, but what we can try to do specifically in this patient populations with immune dysregulation. And then similar to the patient, there was a complicated path to try to figure out with multiple subspecialists involved to try to ultimately get a diagnosis for her that did come, but there are many of our patients that don't ever get that diagnosis.
Okay, thank you very much. Ivona is back. Please, Ivona, can you introduce? Okay.
I have some pop-ups. So do you hear me?
Yes, yes. Okay.
We introduce Dr. Troy Torgerson to the audience at this webinar. Troy is the Director of Experimental Immunology at the Allen Institute for Immunology in Seattle, Washington State, where he is leading cross-disciplinary teams in molecular biology, computational biology, and genetic research to better understand the function of immune system. The Allen Institute is founded by late Paul Allen, who is best known for co-founding Microsoft Corporation with Bill Gates. This is Troy's famous quote I found on Twitter. Not that I'm using Twitter, but it just showed up on Google search. Most people don't realize that the immune system is really an organ or part of an organ system, which is essentially the blood system. Before joining the Allen Institute, Troy was the faculty member at the University of Washington and the Seattle Children's Hospital. Troy obtained his MD and PhD in immunology from Vanderbilt University School of Medicine and completed a pediatrics residency and the fellowship training in pediatric rheumatology and immunology at the University of Washington. Troy's research has focused on characterization of molecular mechanisms of disease in patients with inborn errors of immunity, including autoimmune, autoinflammatory diseases, and also immunodeficiency. He has published numerous articles on diagnostic and treatment of the patients with immune dysregulation. From what I gather, he has done lots of work on X-linked immune diseases such as IPEX, hyper-IgM syndrome, X-linked agammaglobulinemia, and the Wiskott-Aldrich. He has also published several papers on transplantation in patients with various primary immunodeficiencies. Troy is the current president of Clinical Immunology Society, and he is active on many international consortia that are working on diagnostic and treatment of patients with primary immunodeficiencies. I got to know Troy through our work and meetings on the deficiency of ADA2, namely DADA2. One day he came with Chip Chambers to convince NIH team to have the first international conference for DADA2, and that was soon after the papers were published. Then Kastner said that this is impossible to happen due to many reasons. Well, it happened, and it has happened 3 times in the last 4 years. So kudos to Chip and Troy. So Troy, welcome to the ISET Society and to our webinars, and we are all excited to hear your talk.
Thanks, Ivona, for that incredibly generous introduction. I really appreciate it. And I want to thank Clint for presenting the case that we started with, because I think it demonstrates a lot of the challenges that we see with patients who have these immune dysregulation type diseases. I want to just note that Bodo put in the chat that in a patient like this, there's a chance that we could find a matched unrelated donor at some point in the future, which is true. I think this patient has particularly rare haplotypes that it may still be a challenge. So, I think Clint raised at the end of his talk some really pertinent clinical questions that I think we face frequently with patients who have these immune dysregulation disorders, and so that's what I'm going to talk about. And this will be largely clinically focused. So I'm going to talk about, give some background. I'm going to talk about diagnosis and diagnostic challenges in these types of disorders, and then talk about just a touch briefly on non-transplant treatment approaches. And I'm going to spend a fair bit of time on questions around transplant and ways of trying to maybe tackle some of those and get more information so that we can do a better job at this. So just in terms of background, these disorders, what we've sort of deemed primary immune regulatory disorders, or PIRDs, we coined this term out of necessity as we were writing a grant application, but I think it's a useful construct maybe to think about these. So this is from the most recent, many of you are familiar with the publication that's put out by the Inborn Errors Committee of the IUIS, which we review every couple of years, all of the published literature around genes that are associated with an immune phenotype of some sort. And many of you are familiar with this publication that's really become almost a catalog of genes that are involved in errors of immunity. This was the last publication that came out in January of 2020. There were 430 genes listed in that publication, and if you look at those genes, about two-thirds to I guess about 3/4 of them almost really are what we would classify as the more typical presentations of primary immune deficiency diseases, meaning that these are disorders where patients primarily have problems with recurrent or unusual infections. They, as they're sustained with antimicrobials, they may develop immune dysregulation and autoimmunity as well, but really most of their morbidity and mortality is related to infections. And so that's the classic primary immune deficiency disorders, or PIDs. But really about 20 years ago now, this group of immune dysregulation disorders began to emerge. I think just the difference here is that in infection, in the primary immune deficiency disorders, usually the defects here are more on the effector arm of the immune system, whereas here with the immune dysregulation disorders, the defects are more in the regulatory parts of the immune system that control various aspects of the immune response. And so here the characteristic is that patients, most of the morbidity and much of the mortality in these patients is driven really by immune pathology. So immune pathology is the dominant driver of disease here. They may also get infections, and I think there's examples, for instance, in the STAT1 gain of function patients who get chronic mucocutaneous candidiasis and other infections, but again, autoimmunity is a major driver of disease in many of these patients. And so that's the idea here with these primary immune regulatory disorders. So what does this group include? And if you think of this sort of as a universe, some of you may have seen this before, but the idea is that there's a number of groups of disorders that sort of cluster together by mechanism, actually, in many cases, that are part of this. So, autoinflammatory diseases are here as a group. Related are the group of interferonopathy type disorders that often are a result of, I sort of think of them as problems with dealing with cellular debris and as a group. There are also, of course, disorders of the familial HLH disorders that many of them, again, are related to mechanisms of degranulation or regulation of the interplay between the adaptive and innate immune system. Here in this group are a group of disorders that some of these have been characterized by Josh Milner and Stu Turvey have really published many of these initial cases. But here again, gain of function mutations in STAT5, JAK1, that really drive a Th2 dominant immune dysregulation. And then as we move over here, I'll come back to this one in a second, but we've got the group of ALPS type disorders, so non-malignant lymphoproliferation, that have to do with problems of controlling cell growth, whether that's dealing with how cells are told to die or how they're told to survive, but that is a group. And then up here in this corner are the patients with regulatory T cell issues, and so this is the IPEX and IPEX-like disorders that we think are problems with the regulatory effector T cell axis. And then really the new addition to this group is a group of disorders that have really brought our attention to the fact that immune defects in immune pathways can lead to susceptibility to hematopoietic malignancies, and there's a number of these, and this group is actually growing. And then, of course, there's the infantile IBD patients that many of them have inborn errors of immunity, and a growing bridging of rheumatologic diseases across to inborn, genetic inborn errors of immunity. So this is sort of the spectrum of immune regulatory disorders as I kind of think of them. And again, they're sort of binned here by both by mechanism and by presentation together. So we're going to focus most of the rest of this talk on more this group of disorders, but I think some of the things that I'm going to talk about actually do have implications across many of these immune regulatory disorders. So let's talk about some challenges related to diagnosis and that these types of patients present. And the first that I really want to bring up is that something that's kind of unique to immune dysregulation disorders, and that is the fact that somatic variants can drive these diseases and can produce the exact same clinical presentation that a germline mutation in the same gene can cause. And so this is a really nice summary from a nice review article that was published in 2019, where they assemble data that's been published in cases where there have been somatic variants identified. In some cases, these somatic variants are present at a very in a very low allele frequency within the population, meaning that there's a very small number of cells that have the somatic variant that seem to be able to drive disease. And one that we've known about for a long time are these somatic variants in FAS that can lead to the somatic form of ALPS syndrome. And these we've known about for some time, and this has been a great model of these types of diseases. But as time has gone on now, there have been a number of somatic variants that have been identified in genes that you all have great expertise in. So here in the center, so NLRP3, NLRC4, et cetera, that it can cause a disease, an autoinflammatory disease that can look just like patients who've got the germline form of disease. That now has been extended to other disorders, for instance, in STAT3, STAT5B, the KRAS and NRAS, that they're associated with more of a RALB phenotype. So again, this idea that somatic variants can cause problems and can cause full-blown disease, I think, is somewhat unique to these immune dysregulation disorders. And I think the reason for that is that the reason that these can occur is you get a new mutation in one particular cell, and usually the way that these seem to gain a foothold is that needs to confer a selective growth or survival advantage on that cell so that population can expand and drive disease. And of course, that's very unlikely to lead to an immune deficiency, because those cells are, they're more active, more, their survival is better. And so you wouldn't expect that should lead to an immune deficiency, but more likely to lead to an immune dysregulation phenotype. So that creates some real challenges diagnostically. And I would propose that there are probably many more patients out there, and I think especially in the adult world, who have somatic variants that are driving their immune dysregulation. And the challenges here is that the pathogenic variants can be present in only a small subset of cells. So how do you identify these? And if it's only in 5% of the T cells, then you need to either do ultra deep sequencing, where you may get you sequence to a depth of 500 or 1,000 reads, so that you can really say that 5 or 10% of variants in that gene it's not just a sequencing mistake, but in fact it is actually a true variant in a subset of the cells. So that's one way to get at this, but that can be quite expensive to do ultra deep sequencing. Or the other option is that you have to figure out what is the pathogenic cell subset, sort those cells, and then sequence just that sorted cell population. And so this, I think, is an area where it's ripe for development in terms of how we go about doing this more effectively, because I do think that this is a much bigger problem than we know yet in patients who've got immune dysregulation. I want to just introduce you to a couple of recent papers that sort of highlight, other interesting cases of this that were not included in that paper. This is a paper from 2018 looking at patients with pure red cell aplasia, and it's a Japanese cohort. And when they looked at these patients, they had pure red cell aplasia associated with a variety of things. So there were some that were just idiopathic, there were some that were associated with thymoma, some that were associated with autoimmune disorders, and then some that were associated with large granular lymphocyte leukemia. And this association gave them the idea that because there is a somatic defect in STAT3 gain of function mutations that have been associated with the development of LGL leukemia, that maybe these patients, maybe STAT3 gain of function type mutations could be a driver here. So they began a search, and in the end, it turned out that in fact that seemed to be the case here, that that patients, and so showing here that mutations in STAT3 that cause a gain of functional activity that occur just in CD8 positive T cells actually was sufficient to drive pure red cell aplasia in these patients. And so they identified patients with each of these types of associations that had these gain of function mutations in STAT3 only in the CD8 T cell population. And that seemed to be driving this disease. And when they looked at what predicted whether or not they would find one of these mutations, what they found was earlier patients who were younger when they developed this disease, pure red cell aplasia, or patients who were resistant to therapy were the ones that they thought were most likely to have these mutations in the cytotoxic T cells. So again, small subset of cells, selective growth advantage that lead to this immune dysregulation. And similarly, this paper that was just accepted to Blood from Megan Cooper's lab at WashU in St. Louis on gain of function mutations in TLR8 is a very interesting disorder that, again, six male patients characterized, 5 of them were mosaic, and some of them really low-level mosaicism in these gain of function mutations in TLR8. The clinical features are neutropenia, infections, lymphoproliferation, humoral immune defects that are variable, that again, just hypogammaglobulinemia, recurrent infections, and then bone marrow failure ultimately in some of these patients. And in a couple of cases, responsive to bone marrow transplant. And so again, very interesting gain of function in a subset of the immune cells that drives this really profound immune dysregulation disorder. And I refer you to this paper that's now available in EPUB online. So the idea here that somatic variants can drive these diseases really opens up, I think, a whole new, expands the realm of what we want to look for in these patients. And I think, diagnosis of these patients can be challenging, as many of you are very aware because you deal with this on a daily basis. But the phenotypic overlap is tremendous in many of these diseases. And so I list here just 2, for example, and we talked briefly earlier about, Ivona talked about ADA2 deficiency. I think these diagnoses, this is just taken from the literature. These are from the literature in terms of what has been reported to be the clinical phenotypes of patients with ADA2 deficiency. And so here, and then of course over here, STAT1 gain of function in a similar way. These are the published clinical phenotypes that have been attributed to STAT1 gain of function. And of course, there's a lot of phenotypic overlap here that creates problems. And so how do you get to a diagnosis in these disorders early? And I think what the bottom line is that these days, with the ability to do broad-based sequencing at a very low cost, really sequencing first is the most efficient way to try and get at a diagnosis. Now, you may not always find a diagnosis going this route, and particularly, like I said, if there are somatic variants, it can be difficult to find those. But in terms of yield, broad-based sequencing, whether it's a panel or an exome, is really, I think, the most efficient way to try and get at a diagnosis in these PERD type diseases. And then again, we're fortunate to work in small communities of scientists and clinicians, and the ability to email or phone a friend if you've got a puzzling patient is really a tremendous resource for us who are lucky enough to work in this field, and so that can be very valuable as well. So I bring those up as just really diagnostic challenges in the field, and I want to just touch briefly now on non-transplant treatment approaches. So for many of these disorders, because we're identifying genetic defects in pathways where we now have drugs that are capable of targeting those specific pathways, we have the ability to really practice this ideal of precision medicine in many cases, and you can certainly use less specific therapies in many cases, but there's a growing number of disorders where we've got the ability to target the specific genetic defect and functional defect using a particular agent. And I list some of those here, and many of you are familiar with. So, in IPEX, we use T-cell directed immune suppression because we know that effector T cells are a significant driver of that disease. And we talked about CTLA-4 haploinsufficiency and using abatacept or a CTLA-4 Ig. JAK inhibitors in the JAK-STAT gain of function disorders, PI3 kinase inhibitors have been published and are in clinical trials in the APDS. I think and I think the challenges here is that many of these drugs have known toxicities. I mean, we know that these can be toxic in various ways, and as an example, tacrolimus and cyclosporin can have significant renal effects, pancreatitis. They can actually lead to diabetes in some patients. JAK inhibitors, of course, there are risks for herpes viral infections in those patients. And the bigger question is that, we're making these diagnoses many times in children or teenagers, young adults. And the question is, can you stay on these drugs for, 50 or 60 years to try and, hoping that these patients will have a normal lifespan? And so what do we do in these cases when we really, we don't know? And that's where it raises this question about bone marrow transplant and what should we do there to try and approach a curative therapy. So I want to touch base on this because I think that some of the lessons learned here have implications both for bone marrow transplant and also for other newer therapies, cellular therapies, gene therapies that may be coming down the line. And I want to talk through some of those just as to provoke thought. So just as a lead into this, I want to just remind you that when we talk about bone marrow transplant, there's kind of three major aspects here that we talk about, which are the conditioning regimen that patients receive to ablate or clear out their bone marrow and open up space for the donor graft. We talk about the donor and what the donor type is, who the donor will be, what the source, is it going to come from? Will it be from bone marrow? Will it be from cord blood? All of those things have caveats to them. And then the third thing is graft versus host disease prophylaxis. How do you prevent both graft versus host disease and also graft rejection? It's this, how do you maintain that balance until everybody gets used to everybody? The donor gets used to the host gets used to the donor, so that they can live happily together, hopefully for a very long time. And so these are things that play, as we think about bone marrow transplant, these are the three things that we really stress over and really try and understand better how we can do this. So This is published, and I'll just go through it very quickly. We wanted to look within the Primary Immunodeficiency Treatment Consortium. We wanted to understand better how many patients were bone marrow transplants seeing that had immune dysregulation and were being transplanted for this. And so we just asked a few simple questions. We also polled 3 centers within the EBMT who we'd worked with. And so the questions were really, have you transplanted patients for immune dysregulation where that was the primary reason that you transplanted them? And if so, how many have you transplanted? What were their diagnoses and what were the outcomes? And we collected that, and there were a total of 226 patients that were reported to have been transplanted for this primary reason of immune dysregulation. 204 at the PIDDC centers, 22 from those 3 EBMT centers that we polled. And the survival was a little depressing, frankly, as we looked at this. There's an immediate drop off early after transplant. And again, this is taking all comers. We didn't specify which diseases we were looking at. We were asking about here. And I think it highlights that, in fact, what we know from our own experience and what we hear, among colleagues in the field is that oftentimes, especially in the absence of a genetic diagnosis, transplant becomes a last resort. It becomes a salvage therapy in many of these cases. And you go to transplant once everything else fails. And I think that is reflected here in the survival of being, only 55% or so here out at 10 to 15 years. I think that this was the spread of disorders that we collected. So as you can see, there were a lot of IPEX patients in this group. Some of the other big ones were patients that were characterized as CVID but unknown gene defects. APDS was another large group, but you sort of see the distribution here. And again, we didn't ask specifically, we said, just tell us everybody that you've transplanted because of immune dysregulation. So this raised some questions that we feel strongly we need to try and answer, which are, survival is okay-ish, not great in this cohort. I think there's evidence that in other groups of these disorders, it may be better. But how do we improve event-free survival and quality of life? And I think one of the things that's really evident from my own experience in transplanting and being involved in transplant with many of these patients is that the transplant oftentimes, for the most part, stops the severe immune dysregulation, but oftentimes patients are left with significant morbidities, many of which were pre-existing their transplant. You stabilize those, but they're left with morbidities that continue to plague them even after transplant. And we really don't have a very good measure of quality of life and morbidity-free survival after transplant. And it's a major question for these disorders that I think we really need to address. When is the best time to move to transplant? When do you do it? Do you carry them on these non-transplant therapies for a while, and then when they fail those, you go to transplant? Do you go up front? What's the best timing? And how should patients be treated prior to transplant, and how much donor chimerism is required to cure the disease? And this is a really big question in these immune dysregulation disorders. And let me just walk you through the thinking here. So if you look at, if each of these smiley faces is an immune cell, in a normal individual, all of the cells are hopefully mostly happy. And when you've got a germline mutation with restricted expression, so let's take, for instance, the case of IPEX syndrome, where the mutation is in FOXP3, all of the immune cells have the mutation in FOXP3, so as shown here by the X, but only the regulatory T cells are the ones that actually express that protein. And so when there's a mutation in that protein, they don't express that protein, and so they're absent, as shown here by these ghosts. And since the regulatory T cells are absent, all of the other cells are unhappy or they're angry, okay? So that's one mechanism of disease. There's, of course, the group of disorders where there's a germline mutation that's expressed everywhere. So for instance, the STAT gain of function disorders, STAT1, STAT3 gain of function, IL-10 receptor deficiency, the PI3 kinase disorders, all of the immune cells express those. And as a result, they're all unhappy and angry. And so that is another mechanism of disease. And then lastly are the somatic mutations that we've talked about, where you have cells that get mutations that become unhappy as they get those mutations, and they then begin to make their friends unhappy, as shown here. And that can drive disease as a mechanism. So let's think through each of these in the setting of bone marrow transplant and what might happen if in fact you ended up with mixed donor chimerism. So here is this situation. So in this case of a germline mutation with restricted expression, you do a bone marrow transplant and say that you get mixed donor chimerism in the T cell compartment, which we know in IPEX, if you have moderately good mixed donor chimerism in the T cell compartment, you get normal regulatory T cells that come out in pretty normal numbers. And that's actually sufficient to control the clinical symptoms of disease in the rest of the cells. It can make the rest of the cells happy, even though they still have the mutation, because you've only got mixed donor chimerism here. And so that could potentially work in some diseases. Now I'm going to show you some evidence in a few minutes where, in fact, where our thinking is changing a little bit about this, and you'll see what I mean in a few minutes. In this setting where you've got a germline mutation that's expressed everywhere, if you do a bone marrow transplant and you don't replace every last cell, and you leave behind a few of these cells that retain this germline mutation, then those cells, again, because they still have the mutation, they're still angry, there's a risk that they will begin to make their friends angry as well, and cause disease recurrence. And there is evidence in some of these diseases that in fact this can be the case. And then here in the case of somatic mutations, again, if you do a bone marrow transplant for these patients, if you don't get rid of every last cell that bears this somatic variant, again, if there's a selective growth advantage, then those cells may still expand and cause disease recurrence in the long run. And in many ways, these two situations down here look very similar, where you've left behind potentially a few cells that are dysregulated, and they have the potential of being able to drive disease. Now, this, of course, has very significant implications if you're thinking about newer therapies like cell therapies or gene therapies, where, of course, you don't replace every last cell. You go in and edit or change or provide a corrected gene or protein product to a small number of the overall cells. But if you leave behind dysregulated cells in any significant numbers, there's a risk that disease will simply recur. So this is one of the challenges that we face in these immune dysregulation disorders, is how much chimerism do we really need to cure disease? Let me just tell you about our own experience, and I'm going to focus on IPEX because this, I think, has taught us some important lessons. And this is work that that Lori Burrows and I have worked on very closely together. Lori is a bone marrow transplanter here in Seattle that many of you know, and we several years ago decided that we really needed to try and treat this group of patients better, and we designed an approach to treat patients with IPEX with transplant. And what we decided is that for patients who had few comorbidities, who were quite well going into transplant, we were going to use a really myeloablative approach, but hopefully a reduced toxicity myeloablative approach. And to get there, we decided to use treosulfan, which is a busulfan-like drug. It's approved in Europe, not in the United States. So we've been using this on an IND here in the United States. But the idea here is that we would use a myeloablative reduced toxicity approach to try and get better survival and to try and get good grafts in patients, knowing that in IPEX, based on the data that I just showed you, we knew from clinical experience that we didn't necessarily have to have 100% donor chimerism to make a significant improvement in disease. For patients who had significant comorbidities, we put them on a different protocol, which was really a salvage therapy protocol with, it's what we call the Seattle mini transplant approach. And this is just, they get a little bit of fludarabine, some TBI, and then you dump in a whole bunch of cells so to try and drive a graft in. And so I'm not going to talk about this approach. I'm going to focus on this upper approach of this myeloablative reduced toxicity approach and some important lessons we've learned here. So again, looking at these two approaches, this is that myeloablative reduced toxicity approach, looking again at the spectrum of conditioning regimens. Down here, no conditioning. Up here, sort of the classic busulfan, Cytoxan, ATG conditioning, the classic myeloablative conditioning regimen. And looking at the intensity of those regimens, both by immunosuppression and myeloablation, and this sits right up here. It's myeloablative but reduced toxicity. So again, treosulfan, it's a busulfan like agent. It works in the mechanism is very similar to busulfan, but it's reduced toxicity because because of first pass metabolism. It causes less. It has less impacts on the liver and lung, and so you don't get nearly as many problems with side effects like veno-occlusive disease or what people are calling a sinusoidal obstructive syndrome now, and so that makes it less toxic overall. So here it is. So again, focusing on this upper arm, we've now done 10 transplants for patients with IPEX on this protocol. This was a prospective study, so we've collected data prospectively on these, and the bottom lines are in many ways, the first bottom line is that it's really good, which is that of these 10 patients, we have 100% survival from these transplants on this protocol. The downside is this, that in this cohort, of those 10 patients, 6 of them have full donor chimerism, 4 of them have mixed donor chimerism, and over time, the pattern that we see is that they lose the donor chimerism in the myeloid lineage, then they lose their donor chimerism in the B cell lineage, then they start to lose their donor chimerism in the T cell lineage, and that's where we are now. So I want to just get here, and so of those patients who've begun to lose their chimerism, here is sort of a quick summary. So one of those patients has stable mixed donor chimerism in the T cell compartment of around 40%, and he's been stable now for 5 or 6 years and is doing very well clinically. And so he's sort of stabilized and leveled out. However, of the other 3 patients who have mixed donor chimerism, 2 of those patients have now rejected. One of those patients rejected their graft and had to go back for a second transplant 6 years after their first transplant. The other, a second patient has now rejected their graft about 2.5 to 3 years post-transplant. So these are late graft rejections. And we don't know exactly why this is happening, because you would think that if there are regulatory T cells there, it should keep everything suppressed and quiet so that they shouldn't reject. But I think, again, this question is, if you leave behind cells that have the risk of being dysregulated, I think there's a significant risk of ongoing problems. And this is something that we really need to consider and deal with in these. So again, the idea here is that we've got great survival, 100% survival, but now we've got these late graft rejections in these patients, which is very concerning. We wouldn't have known this had we not been running really this prospective trial for the last 10 years to try and answer some of these questions. So again, I think it highlights the value of prospective clinical trials to get at some of these questions. It does raise the question of how much donor chimerism is really sufficient to correct disease. How do we get full donor chimerism without increasing mortality, and how do we prevent late graft rejections? And are we going to see this in other PERD diseases if we leave behind these cells with activating mutations? And so to get at this, Lori has now modified this protocol. We've decided to intensify the conditioning regimen because survival is so good. We feel like it gives us a window to intensify the conditioning. And so we are doing that by the addition of one additional conditioning agent, so that we can hopefully get complete and full donor chimerism in all of the patients right up front, and not risk this problem with graft rejection down the line. So, stay tuned for that. These protocols, of course, are slow to enroll because the patients are relatively rare. As I mentioned earlier, one of the major gaps that we have in the field that we really need to deal with is the fact that we really don't have great data on morbidity-free survival in these patients. So how well are they really doing? What is their quality of life? How, are they really better? I think in many ways clinically they're better. They've got fewer clinical problems, but we continue to see, lots of difficulties with, just challenges in school and challenges with, other issues that come up. Some of those may be related to the transplant regimen. Some of those are related to pre-existing morbidities of the disease. And we're learning about things that happen in these patients as they live longer. So to try and get at some of these questions, we now have, as one of the projects within the Primary Immune Deficiency Treatment Consortium, we are beginning this trial where it's just in the process of going through the regulatory body approval at the moment to look at these primary immune regulatory disorders. This is a longitudinal natural history study. So the idea here is that patients will be enrolled, and everybody will be enrolled on a single arm initially. And we're not specifying treatment. We're gathering natural history data about what therapies patients received and what was their response to those therapies over the long run. Patient data will be collected retrospectively, and then once they're enrolled, it'll be collected prospectively. Transplant is just considered to be one potential therapy that they might receive, and so those patients who undergo transplant will shift to this sort of subarm, and their data will be collected in these time windows going forward. And then if there'll be a comparator group of patients who family members who have the same gene defects but don't have clinical disease. And so our plan is to try and collect around 500 patients from within the PIDTC consortium in North America, the US and Canada, and to try and answer some of these questions that I've raised that I think are really super important for us to try and address with these patients, so that we can do a better job at trying to manage their disease. Patients will be enrolled based on clinical criteria, and these are the enrollment categories here that are a little bit complicated. I won't go into those in detail, but we're really kind of in this group of disorders, we're kind of focusing on defects that we think have impacts on really that regulatory T cell effector T cell axis to some degree. And so we're not focusing on all PERD disorders. We're kind of focusing on that group that sort of, it's the combination of the Treg-opathy sort of group and the non-malignant lymphoproliferation group of disorders that will be the main focus of this particular protocol within the PIDTC. So what have we talked about? Well, we've given a little bit of background here, talked about challenges around diagnosis and this idea that we have to be very mindful of somatic variants and the fact that, in fact, patients can have these diseases and you maybe not be able to pick them up even with standard next-gen sequencing panels or exome sequencing, because the depth of sequencing is not sufficient. So keep that in mind. It is a treatment challenge, or is a diagnostic challenge. The fact that there's a growing number of targeted therapies for these diseases, and this is a very exciting area that I think there will be more and more coming out in terms of hopefully some prospective trials to really help us understand how to treat these patients better with these targeted therapies. And then lastly, we've talked through some of the challenges of transplant. And I think these challenges of transplant are broadly applicable, not just for these disorders, but as we think about transplant and gene therapy for other of these disorders within this umbrella or universe of immune dysregulation. I think that lessons learned here are potentially helpful to inform us as we go forward in these areas. And so I'll just close by acknowledging folks who've contributed substantially to the work that I've presented, and those on the transplant side, particularly Lori Burrows, who's been really my close confidant and work partner for many years now, lots of folks in immunology here in Seattle in Black, and then Alice and Jen and Lisa who've played major roles in helping push this forward at other institutions. So with that, I'll stop and be happy to take any questions. Thank you very much.
Well, Troy, thank you for this fantastic talk. And obviously there is a lot of overlap between primary immunodeficiencies and autoinflammatory diseases. At this point, the only thing I believe into is genetic testing and diagnosis. Earlier, it's better. So I think earlier diagnosis is going to help knowing, of course, what is the cause of the disease, but also it's going to be very informative for the treatment of these patients. So I would like to encourage all the participants to send a question, and I see couple of, actually one question and one comment from Bodo Grimbacher. So his first question is related to the first presentation, and he says you may find a fully matched donor in a couple of years' time. Until then, you may continue with Orencia. So that makes sense, you know, with development of new technologies, with more people donating bone marrow samples for such procedures. I think that, you know, we are going in the right direction. There will be more donors, you know, available, and things may be quite different in 10 years from now. So the second question comes from Mario. Hi, Mario, how are you doing? So the question is, what was the clinical diagnosis of the case Clint presented before the genetic one was made?
Clint, do you want to answer that one?
So, she categorized as a CVID with autoimmune phenotype, and that's how she was predominantly treated. She did have evidence of lymphoproliferation with splenomegaly and GL-ILD, and so that's how we primarily considered her.
Yeah.
Yeah, great. We thanks a lot. We had a little label on our ward rounds that we put on those patients. You usually call them complex autoimmunity, whatever that may be. Usually that was, after several months of negotiations, good enough for us to go into transplant even before we knew what we were dealing with.
Yeah, you know, we've had the same experience, Mario. You know, if there are these patients that had complex autoimmunity that were treatment resistant, you know, or had, you know, or I should say, didn't necessarily respond to typical therapies that were sort of outside the spectrum of normal for whatever their diagnosis was, that oftentimes is a trigger for transplant. And you know, you'd like to see that, in fact, they've had some response to immunomodulators, so that it reassures you that not knowing the genetic diagnosis, hopefully replacing the hematopoietic system will actually have a positive effect. But you know, we've certainly taken a number of patients to transplant without a genetic diagnosis, which is always nerve-wracking, to be honest.
It is.
So Bodo is back with another question. I will just read the questions in the order how they appear on the screen. So this could have also been ADA2, or he meant DADA2, deficiency of ADA2.
Yeah, I mean, I think that the spectrum of disease in this young woman was beyond anything I've seen in ADA2, actually. It was a little more extensive than I've seen in a lot of the ADA2 patients, and some features that I've not seen so much, but it absolutely would have been potentially, I think, one of the ones on the long list of potential genetic diagnoses.
Bodo, do you want to comment or interact?
Hello, everybody. No, I completely agree with Troy. I mean, I don't know about the severity, but the patient didn't have strokes, I see, but in ADA2, we also see this ANA negative rheumatoid-like involvement. So I first thought, you know, it may have been ADA2, and then on a second thought, I thought it's CTLA4. So I think one of those was high on my list of differential diagnosis. And I'm very happy she responded to abatacept.
Yeah, us too.
Can I ask you, are any data on how long they respond good to anti-CTLA4?
Actually, yes. I have my longest patients on Orencia since 2014. Wow. So that's quite a while. I have to say so that she stopped taking abatacept for 2 years because of EBV-induced gastric carcinoma. So we were a little bit wary that this may have been abatacept related. So out of those 5 years now, she was 2 years off. But it still works. So we reintroduced it after she got gastrectomy. And now she's again on abatacept. It still works. Other patients are on it for now 3 or 4, more than 3 years. It still works. So at least, unlike with cyclosporin, where we see a weaning off sometimes after 1 year with regard to the gut disease, the abatacept seems to hold on so far.
Thank you very much.
So the next question comes from Thomas Isekuts, and he says, thank you very much, Troy. For somatic mutations, would single-cell sequencing be another approach, or activating cells and assess transcriptome expression?
Yeah, so great question. So you could do single-cell sequencing. The challenge with single-cell sequencing, of course, is cost. And you know, if these are rare cells, you know, a lot of times you're only, you know, you may only be sequencing 10,000 cells at quite a cost. And so if these are rare cells, again, the question is, do you capture enough of those cells to be confident that in fact you've got a real mutation versus just a sequencing error. So that's, again, it's all about numbers. And I think one of the ways that people have found most effective to get at these somatic variants is to do economically is to do a capture panel. So, and then to sequence ultra deep. So to sequence to a depth of say 1,000 with a capture panel, which cost wise is actually not that bad. You know, to do that, to sequence to a depth of 1,000 in an exome or genome would be prohibitively expensive. You know, for lots of patients. So anyway, these are a challenge.
So actually, I would like to add to this discussion. I mean, we've done, you know, targeted deep sequencing, targeted gene panel where we have like maybe 200 plus genes with a coverage 1,000, you know, or higher. And I ran some patients that presented with late onset disease or late onset symptoms, hoping that we are going to find some somatic mutations in whole blood samples. This was not done in sorted cells. And unfortunately, we just were not successful, at least in a small number of patients that we use this technology to screen for somatic mutations. It didn't work, which doesn't mean that I'm going to stop doing it. I mean, we will continue to do that, you know, but I'm just saying that it's not necessarily going to work, you know, as a technology. I also was thinking about doing sorting cells, you know, and then sequencing different cell types. And also, you know, I was thinking, you know, maybe to use another cell from the same patient where you wouldn't expect the somatic mutations, such as buccal cells, so that you can sort of control for the background peaks. It's very challenging. And then you mentioned also whole genome sequencing. Of course, this is more expensive, although it becomes less expensive with time. Well, I would like your opinion about the paper that I'm sure you are very much aware of, which was published, I believe, last year in Nature or Science, one of these journals, where they sequenced almost 1,000 patients with primary immunodeficiencies by whole genome sequencing. And diagnostic yield was, in my opinion, disappointing, you know, 10%. Some people who are optimists may say, well, that's great. That's better than what we had, you know, maybe 5 or 10 years ago. Yeah. But again, thinking that this was done by whole genome sequencing, and we all have high hopes that this technology is going to really help, you know, in diagnosis of patients. To me, this number was lower than we would have expected to see.
Yeah, I agree. And again, I think there's multiple parts to this. I think number one is phenotyping. You know, being careful about. I mean, it would be great to sequence everybody, and you know, in the UK, they're sequencing a lot of people, and they're finding interesting things. You know, I think sort of broadly across the whole population. You know, it'd be great when we're able to do that, but I think. In terms of looking for disease associations, phenotyping, you know, we forget how important phenotyping is to lump patients together. So that's one thing that's important up front. And then the second thing is that just remembering that whole genome sequencing, it's fabulous, but the depth that most of us get when you send is not terrific. I mean, it's like 30x coverage, 60x coverage if you sort of, you know, go a little crazy. And that's not, you know, statistically speaking, that's not very much statistical power if you're thinking about, you know, rare events. So this is a big challenge that we haven't quite sorted out how to deal with yet. And I think, you know, this is going to be, it's one of the fun things we have to work on, fortunately, you know, so.
Yeah. And we have to think also about copy number variations, and by doing
yeah.
sequencing, you know, definitely, you know, it provides enough data so that we can do searches for copy number variations. Yes, there are many, many factors to consider in this, in all these approaches. So the next question comes from Scott Canna. Hi, Scott. So his question is, given the prep sequencing cost of VES and whole genome sequencing are reaching parity, what can we do to push transition to clinical whole genome sequencing?
Well, you know, I mean, I think that my guess is it's going to be you know, it'll be a natural progression. As you know, as cost comes down, you know, for insurance companies, you know, payment, I think for the most part, they're worried about costs in, you know, in many cases. So I think it'll be a natural transition as that gets, you know, less and less expensive. The other part of that, though, which is a cost that is not, I mean, there's the sequencing cost, and then there's the analysis cost. And remember that an exome is 1/100th the size and the amount of data of a whole genome. So the analysis cost, while the sequencing cost is the same, the analysis cost goes up 100-fold in theory. You know, there is economy of scale, but you do have to remember that piece, which often is not calculated into those thoughts.
I can't imagine that I mean, so right now, you know, the clinical exome people are getting, you know, a couple $1,000s for doing this. And, you know, the time that a processor takes to run an exome or a genome is, you know, pennies on the $1,000 for that. So, you know, following Moore's law, I suspect that as sequencing costs cheapen, processing costs should also cheapen. But your point about the depth of coverage is well taken, although I think it's somewhat counterbalanced by the sort of biases of the capture kits for the exome panels.
So the next question Scott asked is, are we looking at loss of mosaicism in diseases that tend to resolve with age, such as TLR deficiencies or PFAPA?
Fred, we have lost Troy.
Oh.
I'm afraid. Yeah.
Well, I don't know what to tell you. I mean, personally, I'm not a big fan of PFAPA disease, which I know, you know, is totally against everything what is done in our lab. You know, I'm just very worried about the phenotype of these patients and whether, you know, I don't know what to say. So I don't have personally any interest in working with patients with PFAPA diagnosis. I mean, you know, it's a polygenic complex disease. Whether they have somatic mutations, probably they do, but it's just going to be messy. I mean, thinking about multiple genes and, you know, susceptibility alleles and which are not fully penetrant. And then, you know, on the top of everything, you add mosaic mutations. So I am not going there, but, you know, maybe someone younger is going to be more excited about this project. Marco, what do you have to say?
No, it's, I mean, the problem is always the phenotype. I mean, it's very rather confounding, and it's very easy to have the same phenotype, but you are not sure indeed that it is the same disease, and there are plenty of disease. I don't know, Scott, what you think, but I mean, it's rather, and we try even in a selected let's say population of in Sicily, with some families in which there was the PFAPA phenotype, we were never able to come out with a single gene or something like that. It was very difficult because the interpretation of the clinical manifestation in the parents and so on is so difficult, in my opinion.
Yeah. I agree with you. And we heard recently a talk about patients who have germline mutations in the ALPK1 gene that present also with PFAPA-like disease. So the next question comes from Jason N., who I believe is in Canada. Hello, Jason. So regarding finding somatic populations in a patient with systemic inflammation, multiple organ systems affected, apparently both innate and adaptive hyperactivity, how do you figure out which cell populations to sequence specifically, assuming that ultra-deep sequencing is not always possible at all centers? Thank you so much for the wonderful talk. So Troy is back.
Yeah, sorry about that. Things just blipped off suddenly, and I was gone. So, so that's a great question, and I think sometimes you get lucky, and you know. So let me just go back to that Japanese paper that from the Japanese group that presented the patients with pure red cell aplasia. You know, really the break for them came around the fact that the pure red cell aplasia in some patients was associated with LGL leukemia. And in fact, when you look at the breakdown in the LGL leukemia, or in the patients with pure red cell aplasia, 70% of those, I think, is somewhere in that neighborhood, had LGL leukemia, and that gave them the clue that in fact maybe it was a problem with the STAT3 gain of function mutation, and they, you know, then you just sort different cell populations and look at where the mutation happens to lie. You know, again, otherwise it you know, it's going to require really a deep look in some of the patients, really on a research basis, to try and begin to identify which cell types are the ones that seem to harbor the mutation. And some of that can come, you know, I think you might be able to identify, you know, in ALPS, for instance, the cells that have the somatic variant have a very unique flow cytometry phenotype, so they can be identified. And so that can be useful in some cases. You see this aberrant cell population by flow cytometry, where of course you can look at lots more cells at a much lower price point than when you're sequencing. So, you know, I think it can come in a variety of ways, but I think most importantly here, the point that I want to leave you with is this: remember this as a potential disease mechanism, and that sometimes you need to continue to dig on some of these patients to try and get an answer.
Thank you, Troy. Jason, I would also like to add something about the paper. I love to talk about that paper. It's also published by a Japanese group, and it's DSAP, basically, story. You remember the patients had heterozygous mutations in the MVK gene that were identified by GWAS studies, and then we could never understand why they presented just with skin manifestations. I mean, they didn't have any other features of hyper IgD or systemic inflammation, etc. So finally, you know, just thinking from the viewpoint that they have a skin disease, actually they searched for somatic mutations or any mutations in the keratinocytes, and they found the second hit. I love this story. I really think this is a very, very good story, you know, to talk about. So, and next question comes from Nunez Miriam. Excellent presentation. Which immunodeficiency or genetic study suggests determining in a pediatric patient with chronic active Epstein-Barr virus disease and who has had episodes of lymphocytic hemophagocytosis?
Well, so there's kind of two things there. I think so. There are patients with chronic active EBV, so that you know, sort of a disease entity where, again, and again, it may just be our not being very good at this, but we have had very bad luck at finding mutations in patients, primary mutations in patients with chronic active EBV. And in discussions we've had with, you know, with Dr. Cohen at the NIH, who's studied these patients for a long time, I think they've also had challenges with identifying primary genetic defects in those patients. And so I think the jury is out, you know, is that, again, could it be somatic variants? Do we know what's going on there? And I don't know. I think whenever there's HLH, you know, you want to definitely investigate the familial HLH genes. I mean, that's a must, because those are, you know, patients who have those mutations tend to do poorly over the long run. So that's at a bare minimum, you know, you want to look at those. And then beyond that, there are, of course, functional studies that can be done, which are useful in terms of looking at, for instance, CD107A expression on NK cells, looking at perforin and granzyme expression in NK cells. Those have really become kind of almost, I would say, standard of care in patients with HLH type syndromes, just to screen for these familial HLH diseases, where going to bone marrow transplant really is the standard of care now for most of those patients. So I guess that's, you know, what I would say there.
Thank you. So Mario is back again. Troy, there are two papers from 2008 and 9, London and Vienna, if I remember, on donor chimerism only in CD4, CD25, FOXP3 Tregs post stem cell transplantation. All other cells were of recipient origin graft loss. For IPEX reporting good outcome at the time, would be interesting to know how are these doing now 10 years after the transplantation. Do you happen to know what has happened with these patients?
Yeah, there's not good follow-up on a lot of those patients. And, the first patient that was reported in 2001 or 2 by the group in France, the first report of a transplant in IPEX that was in the New England Journal, that patient did well for a couple of years and then had mixed donor chimerism, ultimately just in the T cell compartment, got as low as 16% in the T cell compartment. And then the patient developed HLH and died. And I don't know in terms of the other patients. What I can tell you about our patients is that when you hit the level of around 15%, 15 to 20% in the T cell compartment, donor chimerism, that's when you start to see reemergence of clinical disease. And, when you've got 15 to 20% of T cell chimerism, that seems to be enough because of this selective growth advantage of Tregs to sort of fill the Treg compartment and have those cells be functionally suppressive. But once you go below that, then disease reemerges. So my guess would be that many of those patients have gone on to have some issues. When donor chimerism got down in that range.
Is there anything one can do to sort of prevent, that with, concomitant treatment with some other, therapies?
So people have tried. I mean, we've tried. Some people have tried donor lymphocyte infusions to try and as boosts to try and get stabilize the graft. Those, the data there is very poor, so we don't really know what those outcomes are. But I would say, for the most part, from what we've heard, are not been exceptionally successful. And then we've tried all sorts of immunosuppressive approaches to try and stem the tide of this donor loss, and we have not been able to do it. And I don't think others have found really effective ways to do it either. It's a process that again, we don't understand it, and it is just. It's like watching a car crash in slow motion, to be honest. It's just agonizing to watch this happen, and we got to do better.
Yeah. Okay, thank you. So Miss Catherine Dean, my daughter received whole genome and exome without any of these gene mutations, but clearly has an auto-inflammatory disease. And CVID. Could she still have a somatic gene mutation that this test did not pick up? So would you like to answer this question?
Yes, I mean, absolutely could have. The hard part again is these are a major diagnostic challenge that require a lot of, at this point, we're really research tools to try and get at most of those answers.
Yes, so I would also like to add something about that, so we are doing also a lot of analysis, as you can imagine. And, there is another issue. I think I talked about that in my previous presentation, and this is reduced penetrance. And I really think that this is so complicated for us to figure out. So for example, yesterday I found a gene in one of our patients who has a very, very severe auto-inflammatory disease. It's a great candidate gene. And, if you look at all characteristics of that variant, by in silico analysis, great predictions, high cut score, you name it. It's absent, in population, in any public databases, it's a de novo mutation, and so, do you go after this variant, and do functional studies, or you need another patient, and then you have to find another patient. In another patient, maybe you're going to find a different variant that is going to be identified in one of the parents. So do you drop this project, or you keep going, So there are so many issues, that we have to think about, even if you find a good candidate variants, to put everything, the whole story together, it's a huge puzzle. My personal thinking is that, we are all going to do much better if we collaborate. We have to search for that second patient. That's going to make a huge difference, whether we are going to follow up or not some of these variants. So Bodo is back. He says, my team needs 1 to 2 days to analyze one exome thoroughly. So the analysis will be costly. I couldn't agree more. And, especially when you get to the point to analyze whole genome data, it's just incredible, amount of data, and just to sort out all these variants. So the next question comes from Thomas again. Would it be useful to look a bit more function by using numerous different activation strategies, cytokines, TLR agonists, etc., in multiple individuals? tubes of the patient's cells followed by 20 to 25 color flow and do transcriptome sequencing based on what stimuli are abnormal?
Yeah, so that's a very good question. And I think that's where some of these new technologies could be leveraged. So in my new position here at the Allen Institute, it's really sort of the approach that we're trying to take, which is really deep, a deep look by a combination of 80 plus flow markers, single cell sequencing of PBMCs as a way to try and can we find some tools that we could leverage to do this? I think we don't know yet. I would say there's not, there've been, I think there are a few rare cases where you could that you could refer to in the literature, but certainly that's not broadly available, and the cost of that is, at this point prohibitively expensive for every patient. But I think it's one of the questions.
This is fascinating, but I mean, always come back to the phenotype. I think it's all this technology will help us, but let's not to forget, in my opinion, to stay on the clinical side. I mean, it's very important when you approach it. But this is
amen to that. That's absolutely.
Thank you.
So another question is from Maria Gutierrez. Troy, I have a question about the patient for you.
Is it personal? Huh? If you want to meet Troy afterwards.
Oh, yeah, that's right. I didn't really read through the paragraph. Okay.
Yeah, shoot me an email. Yeah.
Okay. And then we have Jean-Jacques de Braquer, who says, fantastic talk. Thank you, Troy.
Excellent.
And I think I see no other questions on my screen.
Wow.
Okay.
Nice. Please, you finish? I remember next webinar, next week, 11 February, Dan Caster will have his webinar, so don't miss, of course. So if you want to close, thank you again, Tom.
Thank you.
And
Okay, well, I would like to thank you to Clinton and Troy for their wonderful presentation, and also to all participants. And I actually am seeing more questions here, but you can read them. It's just like, saying that both talks were wonderful. So I'm not going to name all these people. And I think that this was a very, very nice webinar, and that, this is how it should be, presentation and then a lot of discussion. And again, I would like to encourage all the participants, to ask the question, and yeah. So keep doing a good job, and I'm looking forward to the next webinar.
Bye-bye.